Welcome. In this session we are going to continue with the infectious forms of uveitis and are going to discuss the remaining bacterial causes of uveitis. In the previous session we have described one of the great masqueraders of intraocular inflammation, syphilis, and here also we have another great masquerader of intraocular inflammation, that is tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis, and this is an acid-fast bacterium, and being an obligate aerobe, it prefers oxygen-rich environment such as the lungs and the choroid, and it causes a chronic necrotizing granulomatous inflammation. And primary infection usually occurs in the lungs by aerosolized droplets and is usually asymptomatic, and systemic disease occurs from reactivation from the primary foci, and 80% of this reactivated disease is pulmonary, whereas 20% is extrapulmonary, and the extrapulmonary forms are more common in immunocompromised states. Fever, night sweats, and weight loss are important symptoms of systemic reactivated disease and are important to inquire about. Now there is a difference in the presentation of tuberculosis or ocular tuberculosis in endemic regions and in non-endemic regions. In endemic regions such as India, tuberculous uveitis is more severe, and it usually occurs in all demographic patient groups. Workup in a granulomatous uveitis patient in an endemic region is directed towards ruling out non-tubercular entities, and in non-endemic regions, tubercular uveitis is usually less severe, and it occurs with certain risk factors usually, such as those arriving from an endemic region after stay or travel, and in patients with diabetes, older age, immunocompromised states, and substance abuse. In contrast to tuberculosis in endemic regions where we need to rule out non-tubercular entities, workup in a granulomatous uveitis patient in non-endemic regions is directed towards ruling out tuberculosis. Ocular involvement results from either an active infection or an immune response to the organism, and uveitis is the most common ocular involvement. The uveitis is typically granulomatous with a waxing and varying course. In the anterior segment we can find episcleritis, scleritis, flectanulosis, interstitial keratitis, but granulomatous anterior uveitis is the characteristic intraocular inflammation of tuberculosis, wherein we find mutton fat keratic precipitates, iris nodules, posterior synechiae, and secondary glaucoma, and this usually occurs along with posterior segment involvement. Posterior segment involvement with tuberculosis unilateral or bilateral, and we can find choroiditis either in a disseminated form, a solitary form, or a serpiginous-like form. In disseminated choroiditis, we find multiple lesions, usually less than 5, but can be hundreds. Numerous lesions are common in immunocompromised states, and in this situation, the choroiditis may worsen even with effective anti-tubercular therapy, and we get small discrete yellowish lesions in the posterior pole deep to the retina with indistinct borders. The other form of choroiditis is the solitary form, where we get a large elevated single choroidal mass with or without exudative retinal detachment and a macular star of exudates. The third form of choroiditis is serpiginous-like multifocal choroiditis, wherein we find a central healing area with peripheral active lesions, and in contrast to serpiginous choroiditis, these peripheral lesions are more discrete from the central lesions, and this form is more common in endemic countries. Periphlebitis from tuberculosis is also common in endemic regions, and they need to be differentiated from Ills disease. Ills disease being an unilateral idiopathic retinal vasculitis. Intermediate uveitis can occur, and other features include optic disc granuloma, optic neuritis, optic disc edema, and neuroretinitis. Subretinal abscess, endophthalmitis, and panophthalmitis can also occur, and choroidal neovascularization can occur as a complication. So here we find retinal vasculitis associated with neovascularization in the nasal quadrant, and we find staining of the involved vessel in fluorescent angiogram, as well as non-perfused areas. This is a fulminating ocular tuberculosis wherein we find involvement of the optic nerve, an area of retinochoroiditis, as well as vascular inflammation. And this picture shows a patient with tubercular intermediate uveitis. Active tubercular choroidal lesions, also called tubercles, on fluorescent angiography show early phase hyperfluorescence and late phase hyperfluorescent staining, and on ICG there will be hypocyanosis both in the early and the late phase. On OCT we find hyperreflectivity of the outer retina and RPE, and also we may find subretinal fluid overlying the lesions, and OCTA shows flow void in the choriocapillaris level in the areas of the choroidal tubercles, and FAF shows hyperautofluorescence in the active stage of the disease. So this is an OCT picture taken from choroidal tubercles near the macula, and this is a conventional OCT, and this is the EDI mode in the OCT, wherein we can make out the area of the choroidal involvement as a hyporeflective area. In most cases, diagnosis of ocular tuberculosis is presumptive, and this is very important to remember. Without direct identification of organisms in ocular tissues, this presumptive diagnosis of ocular tuberculosis is based on typical patterns of intraocular inflammation, exclusion of other possible etiologies, and indirect evidence of prior exposure to tuberculosis. And this indirect evidence can be in the form of PPD test, chest X-ray, interferon gamma release assay, or microbiological diagnosis from other body fluids. The PPD or the Montu test is done with an intradermal injection followed by reaction estimation after 48 to 72 hours. And we have to measure the area of the induration and not the area of the erythema, which is much larger than the area of the induration. And in endemic areas, we need larger areas of induration for a diagnosis. Smaller induration area is considered adequate for those with known prior exposure to tuberculosis, heel tuberculosis lesions, diabetes mellitus, chronic renal failure, and immunocompromise. And there are conditions causing false negative result, as we have mentioned: diabetes, acute illness, immunocompromise, advanced age, and sarcoidosis. So sarcoidosis cause a negative result or NRG on PPD testing, as we have mentioned when we had discussed sarcoidosis in a previous session. Conditions causing false positive results on PPD testing include infection with atypical mycobacteria, vaccination or injection of BCG, and previous PPD test. The other tests for a presumed diagnosis of ocular tuberculosis with typical intraocular inflammatory lesions are chest imaging by X-ray, HRCT or PET. HRCT is a preferred mode of testing. Interferon gamma release assay or IGRA, microbiological analysis of non-ocular tissues or fluids such as sputum, and recently antibodies to purified cord factor antibody has been described to be found in patients with tuberculosis. Now, in contrast to a presumed diagnosis of tuberculosis, a confirmed diagnosis of ocular tuberculosis is based on identification of the organism in ocular tissues. This is performed rarely and is useful when previous tests are negative. In a patient where we strongly suspect the lesions to be typical of ocular tuberculosis, a vitreous tap or a chorioretinal biopsy can be done, and PCR amplification of DNA, transcription mediated amplification of ribosomal RNA, or culture of the acid-fast bacilli can be done. However, the yields of these testing methods are not significant. Treatment of tubercular uveitis, being an infectious form of uveitis, is also two-pronged. We have the antimicrobial therapies and the anti-inflammatory therapy. So the anti-tubercular therapy has certain definitive indications and certain possible indications. The definitive indications are actually a less common scenario and includes patients with abnormal chest radiographs, definitive diagnosis by PCR or culture, and recent conversion to PPD positivity. The possible indications are, however, the more common scenario for patients requiring anti-tubercular therapy, and they include patients with a uveitis pattern suspect of tuberculosis but not responding to anti-inflammatory therapy, a large induration area on PPD test and or a high IGRA, and history of recent exposure. Multi-drug regimen under physician supervision should be administered to reduce the incidence of multi-drug resistant tuberculosis, and a recommended regimen is in the first 2 months the patient should receive 4 drugs: isoniazid, rifampin, ethambutol and pyrazinamide, and in the next 4 to 7 months the patient should receive 2 drugs, isoniazid and rifampin. So the total duration of therapy of tubercular uveitis is 6 months to 9 months and not less. And worsening of uveitis can be found during treatment initiation, and in this situation multi-drug resistant tuberculosis or another possible diagnosis need to be ruled out, and this worsening of uveitis should then be treated with corticosteroids. The other aspect of therapy of tubercular uveitis is anti-inflammatory therapy with corticosteroids, either systemic or topical, but under cover of adequate multi-drug anti-tubercular regimen. The next entity is leprosy, also caused by an acid-fast bacilli called Mycobacterium leprae, and it is transmitted by nasal secretions, and it is the systemic bacterial infection with the highest incidence of ocular involvement. As high as 75% of patients with leprosy will have ocular involvement. The systemic involvement in leprosy occurs in 2 phases. The early phase involves skin and upper respiratory tract, and the late phase involves peripheral nerves, wherein we get bleeding, and also other organs including the eye. And there are 2 major patterns of systemic involvement in leprosy: tuberculoid, in which we find localized, well-defined anesthetic macules and plaques on the skin, and lepromatous, in which we find diffuse, ill-defined erythematous macules, papules or nodules. Ocular involvement usually occurs in lepromatous leprosy already receiving treatment. And adnexal signs of leprosy include madarosis, lag ophthalmos, decreased blink rate, trichiasis and entropion. And as a result of lag ophthalmos and corneal sensory nerve involvement, neurotrophic and neuroparalytic keratopathy can occur. Scleritis and episcleritis has also been described. In the anterior segment, we will find diffuse iris atrophy, miosis, a characteristic of leprosy, iris pearls or diffuse iris lepromata. This picture shows an iris pearl, and beaded corneal nerves. Posterior segment involvement is less common in leprosy. Diagnosis of leprosy is by detection of organism in the involved tissue, and treatment is with rifampin, dapsone and or clofazimine for 6 to 12 months. Topical and systemic steroids may also be required. Nocardiosis is caused by Nocardia asteroides, a gram-positive partially acid-fast bacteria with beaded branching filaments resembling fungus, and it is present in soil. It is acquired by ingestion or inhalation and then spreads hematogenously, and it is more common in immunocompromised states. In the eye, we can find multifocal or solitary choroidal abscesses with vitritis mimicking fungal endophthalmitis, panophthalmitis, orbital and adnexal involvement, anterior uveitis, keratitis and scleritis. Diagnosis of nocardiosis is by culture of tissues and vitreous specimen, and treatment is with sulfonamides, and the patients need prolonged therapy. Cat scratch disease is caused by Bartonella henselae, and humans acquire this organism through the scratch, licks and bites of open wounds or intact mucous membranes by domestic cats, especially kittens, and it usually occurs in children. The systemic form of cat scratch disease consists of papule, vesicle and pustule at the site of inoculation, followed 2 to 3 weeks later by regional lymphadenopathy with systemic symptoms. Disseminated disease can also occur. Ocular symptoms follow systemic symptoms, and the characteristic anterior segment involvement by Bartonella is parinode oculoglandular syndrome, which is the most common presentation of ocular Bartonellosis, wherein we find unilateral granulomatous conjunctivitis with regional lymphadenopathy affecting the preauricular, submandibular and cervical lymph nodes. And the differential diagnosis of Padinot oculoglandular syndrome are tuberculosis, chlamydia, syphilis and sporotrichosis. The characteristic posterior segment lesion of Bartonellosis is neuroretinitis, in which there is an optic disc edema with macular star of hard exudates, and this macular star can be either partial or complete. The macular star may take 2 to 4 weeks to appear and can actually occur after the initial examination, and macular star is said to occur in only half of neuroretinitis cases, the remaining having only optic disc edema. Neuroretinitis from Bartonellosis is most often unilateral and occurs 2 to 3 weeks after onset of constitutional symptoms, and it is said that 2/3 of all neuroretinitis is due to Bartonellosis or cat scratch disease, and the neuroretinitis is usually self-limiting, but macular hard exudates can persist quite long. Bartonellosis can also present with retinitis and vascular occlusions. The retinitis can be solitary or multifocal, with or without choroiditis. Retinitis is actually more common than neuroretinitis in ocular Bartonellosis, but is much less characteristic. Vascular occlusions can also occur involving the arteries and the veins, and vascular occlusions can be sight-threatening. Other possible manifestations can be exudative retinal detachment, retinal vasoproliferative lesions in immunosuppressed patients, because Bartonella henselae colonizes the endothelial cells of the blood vessels, and other ocular structures can also be involved. So the main features of ocular Bartonellosis are that oculoglandular syndrome, neuroretinitis, retinitis and vascular occlusions. And when we suspect ocular Bartonellosis in a patient with a suggestive history and ocular findings, serology should be done with enzyme immunoassay or indirect fluorescent antibody test, and this is said to have a high sensitivity and specificity. Lymph node biopsy can also be done and tested with PCR or culture. However, culture of Bartonellosis takes weeks. In the OCT we can find intraretinal and subretinal fluid with hyperreflective exudates in the area of neuroretinitis, and areas of retinitis and choroiditis show hyperreflective inner retina and RPE respectively. Fluorescent angiography shows leakage from the optic nerve. Bartonellosis is usually a self-limited disease with good systemic prognosis but variable visual prognosis, and treatment is recommended in patients with severe visual or systemic symptoms. Antimicrobials for Bartonellosis include doxycycline or azithromycin for children less than 8 years in whom doxycycline cannot be given, and anti-inflammatory. The effect of anti-inflammatory therapy is uncertain but is often administered. The last entity we will discuss in this session is Whipple's disease, which is caused by Tropheraima whippleyi. It is a gram-positive actinobacteria found in soil and water and acquired through occupational exposure. It is a rare disease predominantly affecting whites and is potentially fatal, and the systemic symptoms are characteristically migratory arthritis and gastrointestinal symptoms in which the patient has intestinal malabsorption, and gastrointestinal symptoms are very important in making an early diagnosis of Whipple's disease. Cardiomyopathy and valvular defects can also occur, and CNS involvement can result in dementia and seizures. Among ocular manifestations, neuroophthalmic involvement is common, with oculomasticatory myarrhythmia being the characteristic, and this we have discussed in the session on nystagmoid movements. The other neuroophthalmic signs of Whipple's disease can be nystagmus, supranuclear palsy and cranial neuropathies. Intraocular inflammation of Whipple's disease is characterized by panuveitis with retinal vasculitis, which is usually bilateral. The vasculitis is typically perifoveal and may cause vascular occlusions, and white crystalline dots in the iris margin and cornea have also been described. Optic disc edema can occur, followed by optic atrophy. A duodenal biopsy should be done when we suspect a patient having Whipple's disease from the history and gastrointestinal symptoms. and we find Pas-positive bacillus within macrophages in the intestinal villi, and this is said to be the gold standard test for Whipple's disease. A PCR of serum or vitreous tap can be done, and this can facilitate early diagnosis compared to a duodenal biopsy. Whipple's disease is a potentially fatal disease if untreated, but responds well to treatment, and the drug of choice is trimethoprim sulfamethoxazole, and Whipple's disease requires long-term treatment of about a year. In patients with allergy to sulfur drugs, doxycycline can be given, and neurologic manifestations usually do not resolve and requires lifelong treatment with doxycycline. Thank you for listening.